Okay, imagine this. You're in the hot seat. Years of training, all leading to this moment. A face-to-face oral exam with a senior surgeon. Your knowledge, your cool, your judgment, everything is under the microscope. Let's get into it.
Right now, that person is you. Let that sink in for a second. You are the candidate. Take a deep breath.
Your exam starts now. Ready?
The examiner pushes the first case across the table. This is it. This is where it all begins. Your job is to listen, process every detail, and start putting together a plan in your head.
Okay, I'm locking in on the details here. So we have a 56-year-old female. Now, the 6 weeks of pain, swelling, and redness, that's concerning. But the real kicker, she had a course of antibiotics and it did nothing. That's a huge red flag. It tells me this probably isn't a simple infection. The exam findings, well, they're classic. A swollen, hard breast is bad enough, but that podorange, the orange peel skin, plus a palpable mass and nodes in the armpit, major alarm bells are going off for a very specific, aggressive type of cancer.
So, candidate, how will you approach this patient?
My response has to be absolutely rock solid, structured, safe, and logical. I'm not going to jump to conclusions. Instead, I'm going to lay out a clear, step-by-step diagnostic plan.
First things first, we need a diagnosis, and that means we need tissue. So my approach is a three-pronged attack. Number one, imaging. We'll get a bilateral diagnostic mammogram and an ultrasound. Number two, a core needle biopsy of the breast mass itself. And number three, we're going to stick a needle in that palpable lymph node in the armpit. That's a fine needle aspiration, or FNA, to see if the cancer has already spread there.
The examiner gives me the results, and wow, they paint a very clear and very concerning picture. The mammogram is a BRADS-5, which is basically radiologists speak for highly suspicious for malignancy. The biopsy confirms our worst fears, invasive ductal carcinoma, and it's grade 3, the most aggressive grade. To make matters worse, it's triple negative. That means the common hormone receptors we usually target with therapy aren't there. The K67 is 60%, which tells us these cancer cells are dividing like crazy. And finally, that axillary FNA, positive. The cancer is in the lymph nodes. This is a bad actor.
A very specific constellation of findings. Candidate, what is the diagnosis?
Based on that classic clinical picture, the rapid onset of swelling, redness, and the poudre-orange, combined with the biopsy proof of invasive cancer, the diagnosis is clear. This is inflammatory breast cancer. It's really important to say that this is a clinical, pathological diagnosis. You absolutely need both the look of the breast and the tissue to make the call.
So, nailing that diagnosis was the critical first step. Awesome. Now, we've got to move to the next phase, figuring out just how far this disease has spread and coming up with our battle plan.
My management plan has 4 crucial parts. First, and you have to say this, is the human part. I'm going to sit down with the patient and her family and break this terrible news with compassion and support. Second, we have to do a full staging workup, a CT scan of her chest, abdomen, and pelvis, plus a bone scan to look for any distant spread. Third, a case this complex has to go to our multidisciplinary tumor board. And finally, the standard of care here is to start with neoadjuvant chemotherapy. That means we hit the cancer with chemo before we even think about surgery.
The examiner nods. The staging workup is negative for distant metastasis. That's a bit of good news.
All right, candidate, no Mets. Give me the precise clinical stage.
The clinical stage is T4D. That D is the specific designation for inflammatory breast cancer. And 1 because she has a clinically positive mobile node in her axilla, and M0 for no distant metastasis. Put it all together, and that makes her stage 3B.
The patient starts her chemotherapy. Now the focus shifts. We need to think about the definitive local treatment that's going to follow.
The examiner lets you know that the patient has completed 8 cycles of chemo and has had a great response. The redness and swelling are way down and the mass is smaller.
She's feeling encouraged by the results, and she asks you, "Doc, since the chemo works so well, can I just have a lumpectomy instead of losing my whole breast?" What do you tell her?
I would start by validating her feelings and acknowledging what fantastic news the response to chemo is. But then I'd have to gently but very clearly explain that for her specific diagnosis, breast conservation is absolutely not an option. With inflammatory breast cancer, the cancer cells aren't just in one lump. They're spread throughout the skin and the lymphatic channels of the entire breast. Even with a great response, the risk of it coming back is just way too high with anything less than a full mastectomy. So the standard of care, the necessary operation, is a modified radical mastectomy.
Very good. And what is your plan for the axilla?
Because she presented with biopsy-proven, node-positive disease from the get-go, she needs a full axillary lymph node dissection. We have to clear out all the lymph nodes in the armpit to make sure we get all the cancer. You know, a sentinel node biopsy, which is a much smaller operation, is totally inappropriate here because we already know the cancer is in the nodes.
You seem to have navigated the case perfectly. But a good examiner always has one more thing up their sleeve. They have a twist, a what-if scenario that's designed to see how you think on your feet when things get complicated.
Let's rewind, candidate. Let's say that initial staging workup wasn't clear after all. It actually revealed a single metastases, a single spot of cancer on her L4 vertebra. The patient is now stage 4. What's your plan now?
And this right here, this is the real challenge of these exams, isn't it? Because with metastatic disease, everything changes. The entire goal of treatment shifts from trying to cure her to palliative care, managing her symptoms and extending her life. The conversation you have with her is completely different. The role of surgery is no longer primary, it becomes highly selective. The whole plan now centers on systemic therapy like chemotherapy and maybe radiation to the spine to control pain. In the Viva, it's how you respond to the unexpected that really defines you. So, how would you manage this?